I want to talk about incomplete caries removal. I want to bring you a sort of state of the science update on incomplete caries removal. And I want to start by showing this radiograph, and please ignore the calculus hanging off of every tooth. And let's tooth number 30. And if you saw this radiograph associated with a patient sitting in your chair, I ask you, what might you start anticipating you might have to do? A pulp cap, a pulpotomy, perhaps endodontic treatment, other referral, or doing it yourself? But if the patient has a deep lesion such as that one half the dentin thickness or greater, but no signs of irreversible pulpitis, and that means it's positive to a cold test, it's negative to percussion, there's no spontaneous pain reported by the patient, and no periapical lesion evident in any radiograph that you have, then the science, the evidence suggests that you ought to consider incomplete caries removal. So these are two different ways of accomplishing the same thing. One leaves the caries in permanently, one leaves it in for a matter of months.
Some people are doing stepwise already because stepwise was advocated and taught by school. And so in that respect, it's not as though it is a contraindication or it is contrary to what you were taught, since it was something that was advocated in school. What we think is that we should probably go ahead and look at longer term studies, but the question would comes in is, how long do we need? And the rate of caries differs from person to person. So knowing when the bacteria is inactive in one person doesn't necessarily make it inactive in another. And so there's just all these questions.
The indirect pulp cap was taught in our dental schools, and it was a, before you expose the pulp, you pulp cap it with calcium hydroxide. So all of us at the table have done it in the past, whether it was doing it from experience that they've had in their practice, but they didn't have to have the research to prove it. They had the patients there, and those teeth would last longer after they've gotten a chance to watch
So
it.
our table, which is over here to my right here, where our question that was posed to us to discuss was the experience with doing direct pulp caps once the pulp has been exposed during caries removal. So our group had lots of experience with this, and through the years of experience that was represented at the table, one of the key things that needed to be discussed is this a mechanical exposure versus more of a caries exposure? And the group thought that there was a big difference between the two, and what they were getting at there was like was presented as it relates to leaving caries in the tooth, there's different factors that are going to be associated with success.
Okay, I'll have to admit, when I first saw this question, I thought this would be about a 2 or 3 minute discussion, and we'll be on to the rest of the questions here. But Table 5 had a very robust conversation about this and took pretty much the whole time. Some of the things that have just been mentioned basically mirror very closely what I'm going to say. The one thing that we all agreed on right up front was the part of the question that says, when would you inform the patient? And that's obviously right up front, less like we do with anything else we do, just to be very transparent. We took it a little step further also, and that is that if you have both patient selection and tooth selection of one, you may want to try this on. As was just pointed out, if you have deep occlusal caries, it's going to be a whole lot easier to seal that than it is if you have an MOD or an MOL, something like that. So sometimes before we get into situations, be careful. Pick and choose which teeth you think this might be most applicable on. And also patient selection. I mean, we know our patients pretty well, and we all have patients that, you see their name in the book and you say, oh, it's going to be a long day. So that may not be the person that you try this on.
That was a suggestion made by one of our table participants, was to maybe think of that as an opportunity for the network to provide a service to its members, and seeing if we could link up some type of better access to full journals, so that when there is a more controversial issue, they can really investigate the full article to see whether they feel as comfortable with it as possible. So I thought that was an important
So we talked about a couple of the barriers that weren't mentioned before, and that actually dominated most of our discussion, even though we were charged with number 4. A couple barriers we talked about was, in terms of adapting something new, was the difficulty given the practice setting you were in and the philosophy that was there. So whether you were in an educational setting that was predominated by older, less evidence thinking, or a group practice that maybe you as an individual practitioner weren't allowed or able to influence the immediate the treatment decision or philosophy, I guess, of that setting?
Well, we had a very interesting discussion in our group. We spoke really about the context in which this can be done. And the first piece is that there are cultural issues. And if we are speaking about cultural differences between researchers and practitioners, we perhaps better start by thinking about our language. And the language, in some ways, one of the suggestions was we need to think about practitioners as co-researchers rather than, and some of the researchers, in fact, are practitioners within the context of their own settings as well. So the language becomes important because some of the barriers actually include issues of language and culture, but there was a discussion about thinking about common interest and finding vehicles for putting people together. But probably the way we decided to present to the group was to think of the metaphor of a relationship. Most of these really depend on relationships between researchers, academics, you could say, or maybe research and practitioners who are maybe practitioners and co-researchers in this process. But that marriage or that relationship requires an understanding. One of the members of our group said it requires a courtship. Maybe that courtship needs to recognize that people need to go into each other's domains to understand what it's like in that setting. Practitioners come into the research setting or the academic setting, and researchers going to the practice setting to find out what their so-called real world is like, recognizing that perhaps in the academic setting we need to think about restructuring. May be very difficult to make it into a real world as well. But that issue of building relationships in the long run has maybe the best chance. It's simple, but it's a way of actually thinking about structuring whatever efforts go to actually put people together. I think we did speak a little bit about the fact that in these relationships there are some commonalities. Researchers or academics tend to be people who come from environments where they're not used to working in teams. I'm not saying all of the researchers, but the need to collaborate and work in teams is becoming more important in research in general. And not all of us are actually equipped or understand the nature of working in teams. And the researchers are solo, in a sense, solo researchers often, who don't work in teams. And practitioners, many of them, are also in solo settings, so at least there's a strong commonality.